Ladies and gentlemen, now we start the next session, chaired by Fumio Imazaki, Thomas Berg. Please start the session.
Okay. Yeah, dear ladies and gentlemen, dear colleagues and guests, it's a pleasure to welcome you. My name is Thomas Berg. I'm a hepatologist from University of Leipzig in Germany, and it's my pleasure to chair this session together with the co-chair, Professor Fumio Imazaki. He's Chief of Medical Office of the Chiba Prefecture Federation of Health and Welfare Agriculture Cooperative. So, without further ado, I think we want to discuss paradigms in hepatitis delta infection. This is a very important topic. And Robert, do you want to start or? Okay, so we changed a little bit the order because perhaps it makes more sense to start with the overall hot topics and the epidemiology, which is then followed by a talk from myself on the new treatment option with bulevirtide, and then by Professor Sakamoto about new testings. Please,
Thank you,
Robert.
Dr. Berg, Dr. Imazaki. This is fantastic. Much appreciate being here. Nice to see so many people in the Delta world. We had about 25 people at the Delta posters yesterday, so that was very exciting as well. And there's lots of activities going on, and I've been given the honor of giving the global framework in the next 20 minutes. This is a hot topic for me, and I've been involved with Delta research now for 14 years. These are my consultants, and there's a lot of slides, a lot of information. I'll have them on my website. Please go to my website. There's a newsletter you can subscribe to also. So we know a lot about the virology of delta hepatitis dating back to Mario Rossetto's time with multiple other virologists and researchers being involved in this. And I'm going to talk now a little bit more about prevalence and natural history. The prevalence data is a total mess. We have estimates in the 12 million range and as high as 72 million. We have a lack of testing and a lack of standardized testing, and I'll go into that in a little bit more detail. It's very interesting. This is a virus that piggybacks on hepatitis B, but the delta prevalence on the right doesn't overlap very much with the hepatitis B prevalence, which is on the left. Delta has a heavy concentration, of course, in Mongolia, Central Asia, which isn't represented here for some reason, but factual. Obviously, Pakistan, there's a number of countries in Africa, but the Africa is spotty because of lack of surveillance. And there's a hot place in northern part of South America for genotype 3 and the Orinoco and Upper Amazonia. It's very much underestimated in the United States, and until just a few weeks ago, one of our two main laboratories in the United States, LabCorp, did not even have delta testing available. There was no antibody, no PCR, and LabCorp represents about 40% of the US insured population. So we have another mess because there was a recent CDC estimate in surface antigen carriers that said delta was 42%. But this is a very special population with special referrals to CDC for this testing. Another problem in the United States, of course, is distribution of our immigrant population and distribution of testing and distribution of awareness. So we have hotspots like Illinois on this map. We have another recent survey that I'm not showing a hotspot in Utah, which is a state that's heavily Mormon, but also has a big immigrant population. But in Utah, ARUP, Standard Laboratory, was the first laboratory in the United States to have delta testing over 11 years ago. So of course, you have a test available, you'll be doing more testing, and you may have a hotspot based on that bias. So here's another interesting issue about laboratory-confirmed delta hepatitis prevalence and patient characteristics. And this is really a study about under-testing. So the testing rate for delta RNA was only 2%. The delta RNA plus antibody test rate was only 11%. And I would say this is very typical for the US because of lack of awareness and lack of test access. We know how bad delta hepatitis is, of course, with a very high likelihood of developing cirrhosis, decompensation, transplant, death, and cancer. But there's also a subgroup of delta patients with very mild disease and very slow progression, We don't fully understand that genotype and phenotype, but there is a large variation in terms of clinical presentation. This is data on adverse outcomes, specifically in people who are delta RNA positive. So antibody test is, of course, step one after surface antigen testing. But everybody must undergo RNA testing, and I'll show you more data how inefficient that process is. We have a little bit more information on liver-related outcomes, especially when combined with HIV. This is an immunosuppressed state. And unfortunately, our nucleoside and nucleotide analogs used to treat hepatitis B in the setting of HIV have little effect on delta outcomes. So triple infection is bad, and quadruple infection, if you have hepatitis C, is even much worse. We've looked recently at healthcare costs and healthcare utilization. This is data again from the US. And there is a step up once you have delta diagnosis, partially because of risk of progression, and partially because we're doing more intensive management of these patients with more frequent surveillance. I call it, you're doing changes in terms of their behavior for alcohol, managing their metabolic liver disease, and more likely to put a delta patient on nukes, not to treat delta, but to treat the hepatitis B. So we have a big problem with our guidelines, and I think we're going to hear a lot more about this tomorrow with WHO, and I'm hoping that WHO will be advocating for delta testing in everybody who's surface antigen positive, but we know that risk-based testing failed. It failed for HIV, we went to testing everybody. Failed for hepatitis C, we went to testing everybody. Recently, in the US, the CDC mandated testing all adults for hepatitis B with a triple panel, and we're hoping to make the next step to get delta testing in all surface antigen positive patients. I'm really hoping we harmonize these guidelines and stop this failed risk-based screening. A little bit more on universal screening here. We have publications that including works that I have done. Dr. Turow, who is a past president of AASLD, dating all the way back to Mario Rossetto, and you will see statements from the Hepatitis B Foundation. And hold your breath that sometime in the next few weeks, Hepatitis B Foundation hopefully will have a statement out about treatment of hepatitis B and delta, which of course is to treat everybody who's DNA positive following the Chinese guidelines. And delta RNA positive, we're going to be recommending treating those individuals as therapy becomes available. Very, very busy slides, but this is really good news. Screening and epidemiology has accelerated rapidly because of new treatments that are in progress. Bulevirtide's approved in a number of countries and being used extensively in Europe. Over 2,000 people are on delta treatment with bulevirtide now, and hopefully it'll be available in the US and hopefully worldwide. This is fueling much updated epidemiology. Again, you can look at these slides a little bit later for more details. Back to testing, Diasorin is going through the FDA right now, trying to get an FDA cleared test. Hopefully that will also go to the EMEA and WHO for pre-qualification. There's a lot of work going on in the delta RNA world as well, and we're collaborating specifically with Roche to accelerate a quantitative delta RNA test that will be available through, again, FDA, EMEA, and hopefully WHO eventually. The WHO has done a great job at trying to standardize this test. This is work that I'm sure Dr. Berg was involved with, Heiner Wiedemeyer, a number of other people with panels, Fabienne Zulim, Emmanuel Gordian, and really trying to harmonize these tests. But we have problems with primer and probe mismatches, variability in delta genotypes, and most of the primers are for delta genotype 1, not all the way up through 8. And of course, we have wide variation in these genotype sequences. This just shows changes in HDV RNA quantification with 3 different commercial assays, including Robogene and Eurobio and VeerCell. So can you trust the number? Well, you can trust if the RNA is positive, it's truly positive. You should definitely stick with the same test over time and not be changing the test that you use, but there is a lot of variability and it can be up to 2 logs. There are barriers to delta screening. We already mentioned availability of tests. We don't have any rapid tests available for delta. There was a very nice presentation from our Mongolian colleagues yesterday developing a new antibody test that could be applicable to a rapid test. Dr. Stefan Urban has a rapid test that's in some type of partnership or development right now, so I'm hoping rapid tests come in. But we really need to harmonize our testing to testing all surface antigen positive tests, and also standardizing HDV RNA tests globally, and really getting our guidance to harmonize and educate the primary care providers. The primary care providers are really at the front line of hepatitis B management in many countries, hopefully globally, and also in terms of the testing. This goes back to screening rates in the US, very, very low, including among healthcare systems who serve at-risk communities. You're looking at screening rates that are maybe up to 30%. That's very, very optimistic. I usually quote 6 to 20% screening rates. And then the prevalence data, of course, is a narrow group on that, but 3 to 6%, I think, is an accurate number for Delta antibody positive in the US, and somewhere between 40 and 75% of Delta antibody positive patients are HDV RNA positive. Again, a wide variability depending on region and probably depending on testing. This is routine screening for Delta and surface antigen positive patients, not performed. France has an advanced healthcare system. They've got great hepatologists, they've got an excellent healthcare system, but 50% of their patients weren't screened for Delta. So even in a relatively unified healthcare system, we can see a failure rate that's substantial. Again, this is Spanish data, Delta screening cascade that was there. 92% of surface antigen positive patients were not screened for Delta in this system. Recalling patients can work. That can improve screening rates, but it's an additional step. Every time you put another step in the process, you're going to end up having patient dropout. But the prevalence data was kind of interesting. Even in terms of the recall rate, we're still running in the 5 to 6% prevalence rate. So maybe under testing has not necessarily led to underestimates about prevalence. Reflex testing, I think, is the future. We have really good data from Spain, which I'm showing here in the far right columns. There's also good data on reflex testing coming out of London, England. There's reflex testing model that's on our poster that we presented yesterday. And I'm hoping sometime in the next 6 months in the US, we convince Quest, LabCorp, ARUP, and Mayo Clinic, our 4 major labs, to move to reflex testing. And we'll call it triple reflex or double reflex. Everybody gets tested for surface antigen positive goes to antibody goes to Delta RNA PCR quantification, not qualitative test. So I'm very active on that through the Hepatitis B Foundation and partnerships with Gilead to try to get reflex testing set up in the US. This will make it much, much more efficient, a much faster throughput. A little bit more on reflex testing. This is just modeling in terms of what screening rates can do. The number at the bottom, you can exceed 90% of patients getting tested if you have reflex testing. Our model from their poster yesterday was in the 80% range. We think this can work. So what's wrong with our communication system? Patients are anti-HDV positive. Only half of those patients, approximately half of these patients, had an HDV RNA test conducted. Part of the reason is in my clinic, where I work in San Diego, we have 42 languages, up to 70 different ethnic groups within a 5-mile radius of our clinic, and these people are very mobile. They come in for a clinic appointment, we find their hepatitis B, we send them for an antibody test. They might come back in a month to 6 weeks, but by then they may have moved on to some other part of the US because of family reasons. The immigration team moves people around the country. Cost of living is very high. We lose many patients. And I think this is also an awareness issue. Many people see antibody positive. They think they're infected with Delta. They connect them to a diagnosis, but we really need RNA testing. We know only half, maybe 60 to 70% of patients are RNA positive in our antibody positive patients. Without effective management, this is specifically treatment, we know that Delta decreases quality of life. You're going to hear some other information, I think, from Dr. Berg about treatment improving quality of life. And there are GI symptoms that were present in ours. There's this anxiety score that has to do with stigma, social stigma, self-stigma, and an impact on daily activities, especially in patients whose Delta RNA positive test was over 2,000 IUs. These people with Delta live with a variety of different challenges. They go in and meet with a healthcare provider. They don't even know what Delta hepatitis is. Again, lack of access to treatment is a big issue. If there's no treatment, people think, well, what am I going to do about this disease? Why do I test for it? Well, I think there's a lot of things we can do with interventions, such as managing metabolic syndrome, stopping alcohol, more frequent surveillance for liver cancer, progressive liver disease. But I think we have a major job to do with education. So hopefully APASL, EASL, AASLD, ALE are 4 giant international organizations will harmonize this education effort. So really we want to get HDV tested in all adults. There's a nice algorithm here that you can look at later. And of course, hopefully very soon, we'll have a US FDA approved therapy. We already have it available in Europe. There's other countries, including Russia, where you can access bulevirtide. There's countries that are near Russia that are also importing bulevirtide into their country for treatment prior to qualification. This is another algorithm that I worked on with Robert Wong and CK, and we came up with this, we think, a relatively simple algorithm. And we also analyzed an all-payer claims database. This represents about 80% of the US. What was interesting about this, and the reason I'm showing this, was what I describe as the under-treatment of hepatitis B in the setting of Delta. In my opinion, anybody who's got Delta should be on a nuke. Basically, anybody with Delta should be on a nuke if they have any detectable hepatitis B DNA quantification. I think that changes outcomes. It slows the disease, not Delta, but slows the hepatitis B disease. I think we need to get this message out. Undertreatment is terrible. Of course, pegylated interferon, the standard of care for Delta, even though not regulatory approved, is also very, very underutilized, I think, globally. So in summary, the diagnosis of Delta requires testing. It requires awareness. We need to move from surface antigen positive to Delta antibody positive and RNA testing by a quantification assay, not qualitative assay. And hopefully we can get reflex testing as standard throughout the world. Where there are resource constraints, we hopefully can have a rapid test or a point of care test that moves forward. There's already been a publication on this from Stefan Urban. There's other tests that are in development, including things that I'm working on, where Delta testing might be as simple as a finger stick, at least for the serologic assay. And maybe we can talk to the NAT companies who have rapid tests for nucleic acid testing, also to get Delta moving forward. We have huge barriers. We need to standardize all of our diagnostic tests. We need to move these through WHO pre-qualification, EMEA, FDA clearance with an intended use for screening for Delta, and of course, moving to Delta PCR quantification. Hoping the guidance documents from all of the international organizations can have that harmonized. And this, by removing conflict, we remove confusion. And then we need to do healthcare provider education, and even community education, I think, is super important. There are very good success stories about B testing and Delta testing. I was in Uzbekistan just a few months ago. They're doing a fantastic job of screening sometimes hundreds of thousands of patients per month. If they're B positive, they're linked to Delta testing. In Tashkent, they have a database of over 18,000 Delta patients as part of their Virology Institute. This has to do with a very systematic approach from Dr. Musabayev by Dr. Homi Razavi, really to bring an example country forward that other countries can look at. Screening rates are low, but through screening, we can link people to better care and to better treatment. There are other medications besides bulevirtide that are in the pipeline, and I think we can make this super simple. I want to thank you for having me for this introductory. I know we have 2 more exciting presentations to come. APASL was very good to us to have Delta poster session and a Delta specific session. Robert Wong, who's my colleague, ELMA HDV collaborators, and wrap things up. Thank you so much.
Yeah. Professor Gish, Robert, thank you so much. Excellent overview. I think we can start immediately, perhaps after each talk, quite specifically, whether there are any questions from the floor. There's a first question, please.
Hey, Bob. Great talk. You mentioned that rapid tests and point-of-care tests, only in really the context of resource-limited settings. But I mean, you said yourself in your clinic, there's people moving on and all this sort of thing. Do you think in even resource-rich settings that these point-of-care tests can improve the cascade of care and lead to more both Hep B and Delta testing?
So Thomas,
care?
great question. The answer is yes. I work with the American Pacific Health Foundation in San Diego, and every month, 2 weekends a month, we're out screening in the immigrant population. We changed from Asia Pacific to American Pacific because we're screening everybody. I've got Haitian, Rohingya, Kyrgyz patients coming in. We're screening with rapid tests for B and C. B is experimental right now, but hopefully we'll have a B rapid test, and Delta would work there, so we can do all three in 20 minutes, get them linked to care. Yes. Thank you.
Please, over there.
Hi, Sakamoto from Hokkaido University. Thank you for the very comprehensive talk. And my question is, for the patient with Delta antibody positive and RNA negative, do you release the patient for follow-up or refer to some specific patient cares?
So this is a great question, and this is what I face in clinics. I have a number of patients from Sudan, Ethiopia. Many of them are Delta antibody positive, RNA negative, normal liver enzymes, no fibrosis on elastography. I'm not going to check them again for Delta RNA. But if they have elevated enzymes, especially if they're nuke suppressed, I would recheck their Delta RNA, especially when we get a RNA qualified test or FDA cleared test. So the answer is yes, I would retest if active disease.
Okay. The other one is, there was an endemic area within the United States. And also I want to ask about whether there is a newly acquired infection of hepatitis Delta still right now, like among the high-risk patients like HIVs or hemodialysis patients.
So 2 parts to that question. These endemic areas are immigrant hotspots and also where we have testing. So Los Angeles, Washington, D.C., we have a very large Mongolian population. Similar in Chicago. So these are hotspots because of immigration patterns and aware physicians. So your second question was on...
Newly acquired.
Sorry?
Newly acquired HDV.
So newly acquired is difficult to diagnose. The Delta IgM antibody, which is for acute disease, is very inaccurate and also not available. So you have to make the diagnosis clinically with some type of risk behavior and also elevated liver enzymes. But it's not reportable in the US except 14 states. So we need to harmonize reporting Delta and have a clinical diagnosis of acute disease. So I can't give you any information, but I'll say from my practice, it's very rare. And I cover 6 locations in California.
Okay, thank you.
Thank you.
Okay, there's another question from the floor in the middle, please.
Liver disease progression depends on...
Sorry, could you go closer to the microphone? Yes, please.
Liver disease progression depends on level of HDV RNA or presence of HDV RNA. And is it really necessary for us quantity PCR test in liver practice?
So our qualitative tests in the US, we have no data. We have no idea how good they are. So at least with quantitative tests, Quest and ARUP have published their performance criteria, so we know a little bit. I believe the higher the RNA value, the more aggressive the liver disease, but that is subjective. We don't have a lot of solid data behind that. But I think in general, and also the higher the RNA, like I showed you, the worse the quality of life. So quantitative should be the standard. Higher RNA value, I think there's some prognosis. Thanks, Pablo. Famous person in Delta. Thank you.
Yeah. Congratulations. So please.
Thank you for excellent overview. I have one question about reflex testing. Reflex testing is a good way to improve HDV screening rates, but in the low epidemic countries, it's not. I think it's not cost effective. How do you think about it?
You're right. The cost of these tests, as you know, even for hepatitis B DNA testing in low and middle income countries is around $100. So it's cheaper to treat than to do NAT testing. Delta RNA testing is even more expensive right now, but it's all about volume, right? Increase your volume, reduce your costs. NAT testing, rapid testing, say on the Affymetrix or Cepheid platform, NAT cost now is $20 per test. And that's again with volume, with a cartridge. There are people predicting NAT testing will be around $7 soon. So if we can get Delta into that $7 to $20 range, I think it'll be very cost effective, but it depends on the cost of the treatment.
Robert, perhaps I can also add a question. And I always wondering why the rate of Delta testing is so low if the people are already diagnosed with HBs antigen. Because normally, and what is the situation in the US and what's your experience from the other countries, if in primary care you do an HBs antigen, Hep B testing, and it's positive, normally these patients were referred to specialized centers, right?
Wrong.
And wrong. And that's the reason, because they are not transferred to specialized centers. But I think also data from specialized centers show that Delta reflex testing is not universally done. Or what's your opinion?
So in the US, hepatitis B is managed 70% with primary care providers. And among those would be gastros who don't do hepatology or do very little hepatology. And they will, I'll quote to you my partner in San Jose. He said, I tested 15 people for Delta, none were positive, I quit. That was the end. So this is at 3 to 7%. The number needed to test is probably 20 to 25 to find one case. So people will run their life off anecdotes, unfortunately. We need to take that thinking out, reflex testing forward, but there's a regulatory commercial issue with reflex testing in the US that if you don't have a specific order for reflex, the lab does not get paid. So we have to work with AREP, Quest, LabCorp, and maybe globally to make sure there's reimbursement through proper coding. That's what we're working on right now.
Okay, there's another question.
Hi, Dr. Gish. It's interesting you highlight prevalence rates amongst certain populations, immigrants, etc. But do you expect any different rates amongst key populations, which are generally harder to access with testing?
So Carlin, the answer is currently yes. We have very motivated people, say in Washington, DC, Jane Pang has gone out to the Mongolian population trying to get everybody tested. We also have a Pakistani immigrant population that's also concentrated. We also have people from Central Asia, the different STAN countries. There's been a focus on testing those individuals, and Eastern Mediterranean. But that's a lot of work. You got to know geography, you have to know risk, you have to get that message to the primary care providers. Total failure, in my opinion. We've got to just test everybody. So I do not see any more questions from the floor, but perhaps one final question, coming more to a holistic approach also in when you envisage what's going on with the fatty liver disease or the steatotic liver disease, the muscle thing, you know, and there's clearly an attempt for the management change that we should have an early diagnosis and to prevent, let's say, end-stage liver disease. And here they're very much focusing on early detecting signs of fibrosis. And I wonder a bit whether we should or do we overwhelm primary care if for hepatitis B, C, Delta, and so on, and then the huge group of patients with steatotic liver disease, we have different ways to approach them and to find them? Or can it be implemented in the one early case findings include those who have significant disease and need treatment? What do you think, that we really combine everything in our efforts to find liver disease at an early stage? So Thomas, it's a great question. In the US, you're a primary care provider, and if you're doing everything that you're supposed to do with every algorithm in primary care, you would sleep 1 hour a day. So what we need is AI to help us with this, to take the workload and responsibility down on the primary care provider, because they know everything about very little, and we know very little about everything. Of course, it's all the specialists, right? Know more and more about less and less. So I think artificial intelligence is going to help us because we have a healthcare shortage. Yesterday, Ray Kim's talk on this SAFE score and healthcare education from an institutional or organizational perspective, we really need to help the primary care providers. We're going to layer on more work. We need to figure out a way to reduce their work. And I think AI may be the only shortcut. What's your opinion?
Yeah, could well be. Not so easy to implement, but I think it will be implemented, that's for sure. Yeah, with easy algorithm or easily to apply algorithm. Yeah, we'll see.
Thank you.
Okay, so I would like to close the first part. Thanks a lot.
Arigatou gozaimasu. Ohayou gozaimasu.
No. Dr. Sakamoto first. Last speaker.
Okay. So you will introduce him?
No, please introduce him.
It's my turn.
If the moderators are confused, it's not a good sign. So sorry. It's my pleasure to introduce the second speaker. It's Professor Sakamoto. And second, so you are a gastroenterologist and hepatologist of the Faculty of Medicine from Medicine Hokkaido University. So please.
Thank you, Chairman, for introducing. And I thank the organizer to give this opportunity to talk in this session. Okay, my COIs. I will talk about the recent prevalence and characteristics of hepatitis delta infection in Japan. I first overview the biological and clinical characteristics of hepatitis delta infection and also a worldwide and epidemiology of the HDV infection. And lastly, I will present my data of HDV infection status in Hokkaido in Japan. This is Hokkaido. It's a northern island in Japan, and 26% of the Japan territory, and lots of good sightseeing place you visit. And also 5% of the total population living, 5.5 million people. And importantly, prevalence rate of HBV are almost 2%. This is twice higher than the general Japan population. Hepatitis delta is caused by the HDV infection. Only a patient with HBV can contract HDV, and also the route of infection is similar to the HBV, like contaminated needles, transfusions, sexual transmission, or mother-to-infant transmissions. And similar to the HBV, it is very often asymptomatic. But importantly, HCV co-infection to HBV may carry a high risk of HCC viral decompensations and early death than the HBV mono-infection. This is a hepatitis delta virus. Delta virus is a single-stranded RNA genome of 1.7 kilobases. And this genome encodes two proteins, long form of HT delta antigen and short form of HTV delta antigen. And C terminal of the long HB delta antigen is plain-rated and specifically binds to the HBs protein and surrounded by the envelope of HBs and form virus particles. It's a little bit bigger than the HBV particle. And the cell entry of HDV infection is by a binding of HBPRES2 protein to the cell surface receptor of NTCP expressed on the hepatocytes. And thus, the infection of HBV is required for the HDV particle propagation and infections. But after once the entry of HBV or HDV into the hepatocytes, the virus life cycle is totally different from each other. Especially in the HDV replication life cycle, there's no step of viral DNA synthesis or reverse transcriptions or propagation of HB core antigens. That means the usually used drug for the HBV infection, like nukes or capsid inhibitors, is totally ineffective for the HTV infections. And there is viral interference of HTV and HPV has been reported. HTV replication is not affected by the HPV replication, but when the cells replicating the HTV, it suppresses the replication of HPV. And when the HTV replication is depressed naturally or a kind of antiviral agents, replication of HPV restores. And clinically, there is two types of HTV and HPV co-infection. One is a simultaneous HPV and HTV co-infection. In such cases, two viruses infect the host in the same times. And the other is HTV superinfection to the patient who are chronically infected with HPV infection. In the HTV co-infection, there is 90% risk of chronic infection. But in the HTV superinfection to the HPV chronic infection, there is a 70% risk that's going to the chronic infection and also cirrhosis or HCCs. And after the HPV and HTV superinfection, there is a 75% risk of chronic disease within 3 years. And in such chronic COD patients have a risk of 70% of developing cirrhosis within 5 to 10 years and 5% risk of 5 years. Such a disease progression rate and carcinogenesis risk is much 2 or 3 times higher than monoinfection with HHPV. As presented by Dr. Gish, HPV and the HTV co-infections carries 3 or 6 higher risk of liver cirrhosis, liver calcinogenesis, or hepatic decompensation, and also mortalities. And I briefly show about the therapies. This slide shows the interferon-based therapy for HDV infection. There is some trial of interferon alpha or peg interferon for 28 or 46 weeks. And such interferon therapy achieved a viral response in almost 50 to 70%, but a high rate of relapse off treatment. Nucleoside analogs have no effect on the HTV infection. Similarly, combination of interferon with nucleoside analog does not have any benefit over the interferon monotherapies. This trial shows the result of recently developed agent. Bulevirtide will be presented by Dr. Barks. It's completed phase 3 trial and is now approved in EU. Lorlatinib is the assembly inhibitor of prenylation. Lorlatinib used in combination of peg interferon achieved a virological response 89%. And peg interferon lambda is better tolerated than the peg interferon alpha. The 48 weeks of treatment achieved a virological response in 50%, but 8 patients have discontinued treatment due to the hyperbilirubinemia. LEP-2139 is assembly inhibition by inhibiting HBS polymerization. Combination used with an interferon achieved both a virological response and also a serological response. Bulevirtide is a peptide drug that mimics HPV PS1 proteins and that disrupts the HPV PS1 to cell surface receptor of NTCP. And yet, use of this drug is specifically declined viral RNA, and in 70 to 90% of patients, virological response can be achieved. In view of such recent development of antiviral treatment, EASU have published clinical practice guidelines of hepatitis delta virus. They recommend screening of HDV infection in all patients positive for HBs antigen individuals. And all patients with hepatitis delta should be considered for antiviral treatment, including bulevirtide or interferon, depending on its liver functions. And now we move to the epidemiology of the Hep D infection. About the hepatitis B infection, there is almost 300 million carriers worldwide and distributing all over the world. And 0.8 million of the patients will die from HBV annually. For the HDV infection, there is an endemic area, is mostly an Africa and Asian country. In the country with high prevalence, it is as high as 30 to 82%. But the problem is in many regional data are unclear due to the suboptimal surveys for HDV infections. This is the situation in Japan, HPV screening status. This is recently published by Dr. Junko Tanaka. In Japan, there is little more than 1 million patients estimated in Japan. But among them, almost 60% of patients has been screened for HPV, and little less than 40% of patients has been properly linked to care or on treatment of nucleoside analog. Still, little less than 50% of the patient has not been diagnosed for the HPV treatment. So we are trying eagerly to increase the screening coverage of HPV infection right now. Okay. In spite of the very eager screening of the HPV, we have very few data about the HDV infection in Japan. The oldest one was 1989, a nationwide study reported by Dr. Yano. Dr. Yano reported that 0.6% of prevalence was reported in all over Japan. Since then, Japan was considered to be the low endemic country of hepatitis delta infection. Still, like in the United States, there is a higher endemic area distributed. And one is the island, Kamigoto Island. Two is a Miyako Island. And three is a Kure City, where the prevalence of HDV infection among HPV carriers is 5 to 20% of the patient. But since 1998, no epidemiological data has been published from Japan. And still, most part of the Japan is not fully screened for HPV infections. Right now, the current status of HPV diagnosis environment is that we have insurance coverage of HPV antibody assays and reimbursed by the healthcare insurance. However, we have no commercially HPV antibody assay kit because one manufacturer finally stopped manufacturing the HPV assay kit in Japan. So we are not being able to commercially check the HPV antibodies. And also in the HPV RNA test, there is some commercial laboratories doing HPV RNA PCR, but very few and cost was the problems. So we try to survey the prevalence of HDV infection in Japan. At first, we exploratory survey the HDV prevalence in Hokkaido Islands. We included patients who visited Hokkaido University Hospital between 2006 and 2020. And we checked an IgG anti-antibody by ELISA kit manufactured by BioBit. And for the HBV antibody positive patient, we conducted HCV RNA PCR. Both we use a kit, but we conducted them in-house. As shown, there is 3 patterns of HPV infection: simultaneous co-infection, HPV, and mostly virus clears, and the HTV, and the second HTV superinfection to HPV carriers, and also the superinfection to HPV carrier who has cleared for HTV. There is several HPV and Delta markers. Among them, IgG type of anti-HTV HTV is continued to be positive at any cross-sectional point after the infection. They use that's why I used IgG type anti-HT for the screening. First, we screened 1,300 patients who visiting Hokkaido University Hospital. 600 has been excluded because there's no stored serums or no valid clinical information. Finally, we screened 601 patients for the HTV test. Okay, here is a result. Among the 600 patient serum, 10 patient serum were positive for HTV antibody. The prevalence rate was 1.7%. Among the 10% positive for the HTV antibody, 4 patients were positive for HTV RNA PCR. And we compare the patient positive for HTV IgG positive and the negative for HTV IgG. HTV IgG positive patients have a significantly higher incidence of liver cirrhosis and liver decompensation as compared the patient was negative for the HTV infection. And also not significant IgG positive patient has a higher tendency of HIV co-infection as compared with the HTV negative patient. And also, HTV positive patient should significantly lower prothrombin times. And hepatitis B related marker was not so different between patient negative or positive for HTV infections. Next, we conducted a propensity match of 2 groups of patients with background laboratory parameters. We conducted 1 patient HGG positive patient with 10 cases and 30 cases HBV IgG negative groups. After propensity match, there is no significant difference between clinical and laboratory parameters within 2 groups. When we compare the progression rate of liver fibrosis as represented by FIB-4 index, there is a significantly higher rate of liver progression of FIB-4 index in the anti-HTV positive group as compared with the anti-HBV negative groups. Progression rate of FIB-4 index in the anti-HBV positive group was 0.22 per year. Similarly, when we use patient on treatment of nucleoside analogs, anti-HTV positive group have significantly higher rate of liver fibrosis progression as compared with hepatitis B D minus progression. That means that in patient with HTV co-infection, progression of liver fibrosis significantly higher, faster, even under the nucleoside analog treatment. And although this different population, when I compared with old data with 1989, 6.6%, this is our data of 0.7%. At least there's no decrease in the prevalence of HTV infection, or even tendency to be increased of HPV infection. And this is one possible explanation for the steady HTV infection is that the HIV infection and hemodialysis infection may be a risk of HPV and also a HTV infection. Both patients are increasing in Japan. I speculate that such an increase in high risk patient might be a steady prevalence of HTV infection in Japan. So, because our hospital is a dedicated hospital to HIV infection, it is necessary to investigate the prevalence of characteristics of HTV among HIV patients across in Japan. And after our exploratory study of Hokkaido Islands, we are setting up a nationwide multi-center study for HTV infection, and it's underway by collaboration with nationwide high-volume centers. Then we can show the result of the prevalence in the near future. Conclusion and take-home message is that still there is a knowledge gap of regional prevalence of HTV infection due to the suboptimal screening. The prevalence of HTV in Hokkaido Island is 1.7%, and HTV co-infected patients show a faster progression of liver fibrosis than those with HTV monoinfections. And in view of the recent development antiviral therapy like bulevirtide, all HPV carriers should be screened for HTV infection. And also, we really need establishment of standardized diagnosis protocols. And nationwide surveys underway in Japan. Okay, here I show the collaborator, especially Dr. Goki Suda and Dr. Sasaki has conducted this HPV prevalence survey. Lastly, we will conduct JDDW in this autumn in Kobe, and I will be the president of the JDDW. We welcome many participants again in Japan in the autumn. Thank you for your attention.
Yeah, thank you very much, Professor Sakamoto, for this very nice talk and showing and sharing the data of the Delta screening in your region. Perhaps this is my first question. Was anybody of the patients, Delta positive patients, aware of the Delta co-infection, or were they all newly diagnosed as part of the surveillance, the screenings?
If we have to explain the patient,
No, I mean, were the patients aware of the Delta infection, or were they newly diagnosed as part of your study?
In our population, none of them are known of their own Delta infection. All 10 patients has been newly diagnosed. But this study includes very old serum. Only 2 patients out of 10 patients are alive and visiting our hospital right now.
Okay, thank you very much. Please.
Komori from Nagasaki Medical Center. I'm very surprised to hear from the kind of recent incidence of the HTV in Hokkaido. So my question is, okay, I live in Nagasaki, and we have already reported kind of the island-dependent high incidence or prevalence of HTV in Kamigoto or even in Okinawa area. So my question is, the positive patients are mostly lived near metropolitan area of the Sapporo, or even from other area of Hokkaido?
Mostly, our patient is mostly Sapporo city or nearby city. Yes.
Okay. Thank you.
Yes.
Yeah. Are there any other questions from the floor? My co-chair, do you have a question?
Yes. Yeah. I have one question. You showed the prevalence was 1.7% recently. In Japan, research on HDV was conducted in 1980s and 1990s that you showed. Do you have any data on the prevalence 30 years ago in Hokkaido area?
There's no study specific for the Hokkaido area. The survey, or the old survey was conducted nationwide, but there should be some sub-data of Hokkaido, but I cannot access the subgroup analysis.
And 10 patients with antibody positive, all Japanese?
Yes, all Japanese.
No immigrants included?
No foreign peoples, immigrant peoples.
Thank you.
Okay, Professor Gish.
Great, thank you. It was very nice. Great education. On the islands with the high prevalence, what was the risk factor for people acquiring delta hepatitis?
I know detail about that. Maybe Dr. Komori know more about it. Maybe some endemic or endemically infected.
Thank you.
Okay, there,
Right.
please.
Hi. Thank you for the nice presentation. I'm very curious about the one data you shared about the increasing prevalence of hepatitis D linked to HIV and the hemodialysis patients. Can you share a bit more on this correlation? And have we seen this also in other parts of the world? Or are you seeing this only in Japan? I'm just curious to hear more.
I don't have any data for that. But there is a report that HIV infection is a risk for HTV, but I don't have any statistical data. I don't know.
Okay, so it's a hypothesis at best right now.
Yes, that might have, because many of the patients has co-infected with HIV. My hypothesis that such a high risk procedure may be a new risk of newly acquired infection HB and also simultaneously and HTV infections. Yeah.
Thank you.
Okay, thank you very much. There's another question over there.
Thank you. Thank you for the excellent presentation. My question is that you had shown the data of fibrosis, the difference between the anti-HDV positive and the negative patients. Did you also do a sub-analysis for patients, stratifying them based on RNA positivity?
It's a good point, but because there is a few patients with positive for hepatitis delta, only 10 patients. We don't have any. We don't see any tendency to IV positive in the progression of liver fibrosis.
Thank you.
Okay. So thank you very much. I do not see any further questions. Thank you very much again for an excellent talk.
Move on to the last one. The third speaker is Professor Thomas Berg. He is the head of the Division of Hepatology and Deputy Director of the Department of Medicine at Leipzig University Medical Center. Please start your talk.
Yes, thank you so much. So, dear colleagues, it's really a pleasure to be here and really want to thank the organizer in Nepal for organizing this symposium on hepatitis delta and inviting us. So, I want to talk about the new treatment option we have in Europe with bulevirtide and discussing a bit navigating from the clinical trials to the real-world experience and whether we are on the way, on a course towards hepatitis delta cure. But I wanted to start with the interferon era to give a kind of a background of where we came from. And You know that interferon is still an established, and it was for a long time the only treatment we had for hepatitis delta. And what we could achieve on treatment is approximately around 40 to 50% patients responding. The virus is responding and achieving undetectable levels, but you are quite aware that the problem was that after stopping treatment, and even if you have extended PEG interferon for 2 years, the risk of relapse is very high. On the other hand, if you achieve undetectable level of HDV-NA, this changes the course of the infection. This has been shown in the interferon era with the overall decompensational events or the overall survival. And you have seen here from many slides that independent of the response of the patient, it's better to have a treatment without in comparison to those who never received any kind of treatment. And it has been shown that nucleoside analogs as a monotherapy are also ineffective in this infection. Now let's move forward to the entry inhibition with bulevirtide and whether this is a magic bullet. And you know, hepatitis D virus enters the cell via the hepatitis B envelope, via the anti-CB receptor, and it has been already shown its part, the bulevirtide is derived from part of the Pre-S1 region of the hepatitis surface antigen. And this blocks entry of the hepatitis B virus. But NTCP is not only the entry virus, of course it has a biological function, and it's the main receptor for the bile acid transport. But what is important to realize that the amount, if you like, you need to block hepatitis delta or B entry is much less as you would need in order to block bile acid transport. So although it's the same receptor, bile acid transport is still functioning, it's working, although to a bit a lesser rate. So what we see on treatment is a slight increase in bile acids on treatment. And I think another point when talking about bulevirtide is that we are used to antivirals. And also in a way, interferon is an antiviral because it also blocks viral production. Now for the first time in hepatology, we have an entry inhibitor. And an entry inhibitor, of course, blocks entry, but this means that if you have a cell that is already infected with hepatitis delta virus, this cell can still produce hepatitis delta antigens, viruses, RNA, so it's not directly affected by the entry inhibitor. So coming to the experience we have first from clinical trials, and then we move forward to the real-world experience. There are 4 main studies that have been conducted with, in the beginning it was Mercledex, as you know, now bulevirtide. There are 3 2-phase studies, 1 already published and 1 phase 3 study quite recently published in the New England Journal of Medicine. The published studies are studies that are dealing with bulevirtide monotherapy, and there are 2 other phase 2 trials with combination with PEG interferon. And you see what the endpoints are that were agreed that you should achieve at least a 2-log decline in HBV DNA with an ALT normalization. This is the on-treatment response, and this is then in favor, if you achieve this, to continue treatment as a chronic therapy. On the other hand, if you go for finer therapy, the agencies ask for undetectable HDV RNA levels once you have stopped treatment. So what about the results from the phase 2 early trials and what we learned from them? The first trial was only 24 weeks of treatment, and you see here the virologic response rate overall with this endpoint 2-log, at least 2-log decline. You see around 50% responding to this treatment. There's a bit of dose dependency with higher response rates, with a higher dose of bulevirtide, but you see if you stop, and this was the first lesson we learned, then there's an immediate relapse in HDV RNA and in a similar way with the ALT levels. And another lesson we learned from these early phase 2 trials that there's a variability in the virologic response. And you see here's a great variation in the decline of HDV RNA in the 2 and 5 milligram dose. And another lesson learned is that HBs antigen is not affected by the entry inhibitor. Of course, you stop the delta entry, but integration of HBV DNA production of HBs antigen is not directly influenced. The phase 3 study I would like to briefly summarize. You see here the log decline, 2 different doses were tested, the 2 and the 10 milligram. You see a bit of faster decline, a more pronounced decline with the 10 milligram, but overall a very nice decline. Most patients had a decline of more than 2 log and about 50% normalized the ALT level. If you look at the combined response rates, it's 45% and 48% in the 2 and 10 milligram, and this was achieved after 48 weeks of treatment. The study is still ongoing, and perhaps it's good to keep these numbers in mind when we come to the real-world data. And what we really want to achieve, of course, is undetectable HDV RNA level, and after 1 year of treatment, this was achieved in 12% and 20% in both treatment groups. There's a very interesting observation and sub-study from these clinical trials, because in a certain percentage of patients, there was a baseline biopsy and another biopsy taken after 24 or 48 weeks after treatment. And the authors looked about what is the reduction of intrahepatic HDV RNA, what about the reduction of HDV-infected hepatocytes, are there any changes in the expression of inflammatory parameters, and how does it correlate with serum markers? And just to show you some of the very interesting results, and first here the change of intrahepatic HDV RNA in the 2, as depicted here, and the 10 milligram dose. And you see that most patients also intrahepatically show a nice decline of more than 1 log, but perhaps even more important, in the 2 and the 10 milligram dose, 37 and more than 60% achieved undetectable levels in the liver, and this was only rarely achieved in the control group. And the good news is that there was a nice correlation between serum HDV RNA and intrahepatic RNA, so you can judge a bit from what you are measuring in serum, what's also going on in the liver. Here you see the delta antigen staining in the control group, and here in the 2 treatment group, before treatment and after 48 weeks. And I think it's quite nicely to see that you get rid of most of the HDV antigen positive cells after 1 year of treatment. An interesting observation was the test of the expression of inflammatory markers, and here they checked mainly for chemokines, inflammatory genes, but also the classical interferon-stimulated genes. And what you see here in blue, in comparison to baseline, is a reduction in the expression of inflammatory genes. So the more blue, the more pronounced the reduction was. And again, there was a nice correlation between the reduction you have seen in the inflammatory markers with liver RNA, liver HDV RNA, but also ALT changes. So the normalization we see in ALT levels under treatment are reflected by a less expression of inflammatory cytokines within the liver. Now, what about the combination with PEG interferon? What is the rationale about this, and what are the results and the outcome from clinical trials? And I want to start first with the rationale why to use interferon. And I've mentioned that with bulevirtide we can effectively block the new infection of uninfected cells and thereby preventing the spreading of the virus within the liver. But there's another route delta can spread within the liver, and this is by cell division. So if a cell divides, both daughter cells will get infected or remain affected, if you like. But it has been nicely demonstrated that with interferons, by the interferon-stimulated genes, you can prevent this cell division spread of hepatitis delta virus. So what are the results? And I mentioned we have 2 combination trials that are helpful in exploring the efficacy of the combination therapy. The first one, it was a small study, and you see in comparison to the bulevirtide monoarms, those where PEG interferon was added had a much faster decline in HDV RNA. More data were, or a larger group of patients were treated in a study, another phase 2 study that was recently presented by Tarek Asselah at the AASLD meeting, where patients were treated with a combination with 2 or 10 milligram for 48 weeks, and then interferon was stopped, but then patients could continue with bulevirtide either 2 or 10 milligram. And what you can see, and this was one of the major endpoints, it was 24 weeks after stopping interferon. And you see here that 32% in these 2 arms and 46% in the 10 milligram arm, 24 weeks after stopping PEG interferon, still had undetectable HDV RNA level. And I think this is a quite remarkable result. And in the control arms with PEG interferon mono, it was only 17%, quite similar to what we have seen in the classical interferon studies. And in the 10 milligram mono arm, it was only 12%. Now we're moving forward to the real-world experience. And you know that in 2020, the European agency approved it on a conditional level, and in 2023 it got full approval. So it's licensed with a 2 milligram dose plus minus nucleoside analog therapy. And to make a long story short, I think what we have seen in clinical trials could be repeated in real world. Just showing you here the undetectable HDV RNA levels, and the longer you treat, the more patients achieve the undetectable goal, here reaching something more than 40% after 96 weeks. And when you look for the combined endpoints, a 2-log decline plus normalization of ALT, you see here even more than 50% achieving this endpoint when treated long enough. There is a French study, an early access program, where they also used the combination therapy. Interesting data, because they treated either with mono or combination therapy for approximately 1 year, and then either stopped, continued combination or continued monotherapy arm. And you can clearly see here the difference in the kinetics of the HDV RNA decline. After 1 year with monotherapy, only 32%, as compared to 71 in the combination arm. But with ongoing long-term treatment with a 2 milligram, you achieve similar level. So time matters here in the monotherapy group. We have some data in patients with cirrhosis, especially in compensated, very few in the decompensated one. Again, it looks like that cirrhosis does not affect the efficacy of bulevirtide. If you look here at 96 weeks with a 2 milligram dose, 46 achieved undetectable level, 72% of virologic response, and nearly 60% ALT normalization. Very few data in the decompensated one. So we have 19 patients from European sites that have been treated for an approximately median of 41 weeks. And you see again here, the virologic response rate are quite similar of what we have seen in the patients without cirrhosis or with compensated cirrhosis, and quite similar as with hepatitis C. We are starting to see even improvement in some of these patients as depicted here by the MELD score. Now I would like to move forward with how to deal with the variability in response rate and how to explain or why is there a discrepancy between the virologic and biochemical response. And this is quite striking. And if you look here at patients with different levels of virologic response, either undetectable level or there's still nearly 10,000 copies or a unit there, you see this is not reflected in any way by the ALT levels. Regardless of the response group, the ALT response in all groups is nearly the same. And even if you go for the clearly defined non-responder patient, as done here in a German real-world cohort, after 12 weeks, there's also in the patient with viral non-response a nice decline in ALT level, perhaps a bit less pronounced as in those with virologic response. But if you wait 12 weeks longer at week 24, it's nearly identical in terms of ALT normalization, whether you're a responder or non-responder to treatment. But how to deal with a virologic non-response? Are there any stopping rules if patients do not respond in the best way to the treatment? And again, here we have relatively well-conducted data of patients being defined as suboptimal response at week 24, either as non-responder, less than 1 log decline, or partial response, less than 2 log decline. And if you follow these patients in these two categories, you see with continued treatment, more than 60% end up in the virologic response rate. You see a decline over treatment duration. You also see a decline in the ALT level. And if you look only to these 5 patients who throughout the course of the treatment have less than 1 log decline in HDV RNA, you still see in this population a marked decline in ALT levels. But how to deal with this virologic non-response, and is there any evidence for HDV resistance? Because if you look at these typical courses we see in clinical practice, you know that in some patients you have a decline like this, and then again a rapid increase, and this also shows a typical patient normalization of ALT, but really this fluctuation of the HDV RNA. So a study was done with all the samples available in patients according to their different response. And as you can see here, the in vitro phenotypic data of the bulevirtide EC50 of the virus with different amino acid substitution in the HBV pre-S1 or delta antigen region do not show any change. Neither was there any change in the EC bulevirtide 50 with respect to the different genotypes, or if you look in the different categories, whether you're non-responder, partial, virologic responder, or delayed treatment, the EC50 for bulevirtide is identical in all these different groups. So no evidence at all for resistance. I want to give you some insights and lessons learned from early viral kinetic studies, and whether they can help us in our way as a roadmap to cure. And there's one study that compared the monotherapy with a combination therapy for 1 week, and they modeled what they have seen in the first 48 weeks, how it can predict the level of cure rate or undetectability rate you can achieve in the long term. And here the data they had after the first year of treatment, and again you see the variability in the response, and you see how much faster the addition of PEG interferon influenced viral kinetics. And they did this model, and they forecasted that there's a cause of a kind of a cure boundary you have to achieve in order to get rid of the virus. And this boundary, it's much faster achieved if you have the combination therapy. This is a level of quantification, and this is a boundary where you can be sure, or it is predicted, that no virus is anymore left. And you see it's much lower if you treat with bulevirtide monotherapy to achieve this boundary. And if you stop interferon after 1 year, you have a delay in achieving these boundaries. And what they could predict from these data is that you go for 3 years of treatment with bulevirtide monotherapy, you can perhaps achieve undetectability rates of approximately more than 60%, but more than 90% if you have been treated with a combination therapy. And therefore, they predicted that after 140 weeks of treatment, viral cure rates could be achieved in 42% with bulevirtide alone, versus 67% with a combination. Now I would like to summarize what we have learned so far. So in untreated patient, you have the de novo infection of so far uninfected cells by hepatitis delta. And then you have the spread of hepatitis delta by cell division. And there are some cells that might be called resting HDV positive cells. So with an entry inhibitor, you can get rid of the extracellular spread of the virus, but you will not affect cell division. With interferon, by blocking production of the virus, you will reduce number of uninfected cells becoming infected, but you will not get rid of newly infected hepatocytes. But you could get rid of the cell division-based spread of the virus. So combining these things have a high chance for curing these different modes of delta spreading, and with time perhaps you could get rid of these resting cells just by apoptosis and the natural turnover of hepatocytes. So can we stop bulevirtide after serum HDV is no longer detectable? And there was the very famous Milan patient. He received a 3-year course of bulevirtide monotherapy, and then treatment was stopped. The patient was followed for more than 1 year, and after 48 weeks, again, after stopping treatment, a liver biopsy was taken, and HDV antigen staining was negative. But perhaps more than a year of follow-up is not enough really to show cure for hepatitis delta. It's clearly different from hepatitis C, and in this patient, after nearly 3 years of follow-up after stopping treatment and having undetectable level, the patient suffered a relapse after 132 weeks of bulevirtide therapy. This is the best data I can show you about stopping treatment, and it's a study here from Austria, recently published. So they were able to follow 7 patients who stopped bulevirtide following 46 to 148 weeks of treatment, some with interferon, others without. And during the follow-up of up to 112 weeks, 3 showed a relapse and 4 were still HDV RNA negative. Well, I would like to conclude my talk, and if you are interested more in how to treat and everything around also the epidemiology and disease burden of hepatitis delta, I would like to refer to the recent EASL guideline, and I would like to summarize that the experience in the treatment of patients with chronic hepatitis delta using bulevirtide monotherapy has been steadily expanding, derived from both the clinical trials, but also very important real-world studies. Bulevirtide demonstrates effectiveness regardless of the severity of the liver disease, and the efficacy of monotherapy tends to improve with continued treatment over time. With extended treatment duration, there is theoretically a chance for cure of delta infection, and this chance for cure can be increased by combination therapy with interferon alpha. And modeling studies provide a rationale for individualized therapeutic strategies based on viral kinetics. But of course, there are several unanswered questions. These are the factors influencing treatment response, precision, patient and treatment duration selection to optimize treatment outcomes, the strategic advantage of primary or secondary combination therapy, and whether they're really non-responders and whether we need for them stopping rules. I thank you very much for your attention.
Thank you for excellent talk on the treatment of Delta virus infection, hepatitis. Thank you very much. Any comments or questions from the audience? Please.
Komori from Nagasaki Medical Center. So probably it is out of your scope of presentation. I would like to know about the influence of the HBV on HDV. So I know the ongoing clinical trials for the antisense oligo or siRNA for HBV to reduce the amount of HDV. How would be your impression for the kind of future trials?
Yeah,
So
well, of
about
course,
B?
the siRNA trials, in order to really reduce or to block S antigen production, I think it sounds quite logical.
Yes,
But you know, the experience we have seen in clinical trials, they were less successful. And sometimes there were even something that you have seen an increase in ALT level, and it's not really clear what happened there. It could be, you know, that it could be a kind of a toxic effect of accumulation of HBs antigen, not anymore used for packaging the Delta virus. But I think it's a bit unclear what's going on there. I think the sole focus on HBs antigen as a main endpoint marker is a bit difficult, and it clearly shows that you can cure, perhaps from the limited data we have, you can cure Delta without curing hepatitis B.
Great talk, Thomas. Vir is developing an iRNA targeting Delta, not B. If you were going to develop an interfering RNA, where would you target in the viral genome?
Well, this is a difficult question, to be honest, and I'm not sure whether I can give you really a good answer how to best do it. Well, of course, the Delta antigen region sounds quite logical, but I can't really give you something that, is really convincing, or I'm quite sure about it,
It's great there's so much interest. Thank you.
Yeah, thanks.
Please.
Okay, Dr. Sangtyo from Mongolia, and thank you for your great presentation. I'm just asking about the side effects or some other disease related during the bulevirtide treatment, because in Mongolia, the bulevirtide and pegylated interferon is available in recent years. So in our center, we have 10 patients who underwent the bulevirtide treatment, and 3 of them developed the renal stone during the treatment. Whether I'm just asking what kind, do you have this kind of patient?
You mean gallstones, right?
No, gallstone, the renal stone, kidney stones.
Kidney stones.
Yeah.
No, we haven't seen kidney stones so far, and I'm not aware of any systematic data also reporting about this, so it's interesting, and I think we have to follow this. Well, it's a subcutaneous injection, and the patient have to inject every day, but because really patients are so much concerned about the disease, we have the feeling that adherence to therapy is quite high. And also in these patients where we have seen this fluctuation or even a non-response in terms of HDV RNA decline, we can see there is an increase in bile acids, so we do not think that it is an adherence matter, and overall treatment is well tolerated. I agree, we all got a bit tired in treating patients with interferon, with all these side effects. Of course, it makes a difference whether you add ribavirin. Interferon monotherapy is a bit better tolerated as compared to our experience with a combination in Hep C, but still, I would say it's a nasty drug. But if it would help, as long as we have better substances to cure patients with a limited treatment duration, I think it's still reasonable to consider also this kind of combination therapy.
Nice presentation. Thanks a lot. I'd like to ask you about main predictors of relapses: fibrosis, viral kinetics, age of patients.
It's funny that we do not have really good data about this, but I think it really looks like that the level of viremia matters. And to be honest, I've never seen a patient, let's say, with 5 log not responding completely to bulevirtide. There are mainly those with 7, 8, 9 logs where you see these. Perhaps it's a time matter. We have just to wait for extended period. And if you look to those patients I mentioned in the Austrian study that were cured with a follow-up we have, they started with a very low viremia when they were treated with bulevirtide mono. Those with PEC, in addition, they started with higher levels. So I think there's a clear relationship with the level of viremia and the chance to get rid of the virus.
And I'd like to ask you about liver disease progression in non-responders on bulevirtide during antiviral therapy on 144.
Yeah, you know, this is really an interesting question. So far, we do see improvement. And this is more related to the level of ALT decline. And, you know, if you do not see any more markers of inflammation, but you still have high level of HDV RNA in the blood, you may think about, is it similar like S antigen? You know, you have a lot of S antigen, but if there's no inflammation related to this. So this is a very important thing I think we have to study. And therefore, we do continue treatment if we see a good biochemical response, even if we do not see a virologic response. But I think it may really depend on how long we continue treatment, because just by preventing the spreading of the virus, we could see remarkable results, perhaps even after 4, 5, or 6 years, so that in the end we will see also virologic response with long-term treatment.
So it will be long-life therapy like in hepatitis B?
Well, it's an RNA virus, so I'm a bit more optimistic, and my guess is that we have earlier a Delta cure before we get a hepatitis B cure or curative therapy.
Thank you.
Any other questions? No? So thank you very much, Dr. Tom.
Thank you so much. Okay, so I was asked to close the session, so I really want to thank all the speakers for excellent presentation. I want to like to thank you for excellent discussion. We really filled the time. I was in the beginning a bit concerned. We had half an hour for discussion, but it worked well, and we can close in time. I wish you a wonderful APASL meeting. Thanks a lot for being here.
Thank you very much.
Thank you very much, the lecturers and moderators.